Welcome to Harm Reduction Strategies for People Who Use Fentanyl. My name is Merlene Tucker, and I'll be running this Dialogue for Health web forum alongside my colleague, Jeff Bornstein. Thank you to our partner for today's event, the National Overdose Prevention Network, a program of the PHI Center for Health, Leadership, and Impact. Let's go ahead and meet the moderator of today's event, Dr. Mary Maddox Gonzalez. Dr. Gonzalez is a coach and preparedness consultant for the California Overdose Prevention Network, a program of the PHI Center for Health, Leadership, and Impact. She served as the Sonoma County Public Health Officer and Division Director and the Chief Medical Officer of the Redwood Community Health Coalition for Sonoma, Napa, Yolo, and Marin counties. She has been a board member and chair of the Latino Coalition for a Healthy California. Welcome, Mary.
Absolute pleasure to be with you all today. Thank you so much for joining us from around the United States for our program. You're going to learn some incredibly helpful information about fentanyl and how we can prevent overdoses with fentanyl. You'll be learning about what harm reduction strategies people can use with fentanyl, and that whether that is intentional fentanyl use or accidental fentanyl use, but primarily when people are using fentanyl intentionally. Participants are also going to better understand how we can work most effectively with people with lived and living experience, and then also learn about some opportunities to center people who use drugs within the work that they're providing in their communities, that this always be people-centered care and services that are provided. Can I have the next slide? Okay, and as we've talked about, these are harm reduction strategies for people who use fentanyl. And the next. And it's now my pleasure to introduce our guest today on today's presentation, Andrea Figueroa, and she is the DOPE project manager for the, which is part of the DOPE program is part of the National Harm Reduction Coalition. And Andrea has just this very rich cultural and experiential background that she brings to this role. She's lived in New York, Chile, Montreal, and as well as Montreal, Canada, and now in San Francisco. I don't know if you're living in San Francisco, but definitely working in that area. So for over 20 years, Andrea has been working in harm reduction and community organizing. All of this work has been rooted in solidarity, liberation, and compassion. Before she came to the DOPE project, she worked at the largest supervised injection site, also referred to as SIS, in Quebec, Canada. She was initially a community worker there and then worked as a nurse there. At the same time, she was also the director of a youth clinic that provided care for youth who are non-status, which is a term used in Canada, similar to the term undocumented here in the US, and for transgender, queer youth and marginalized youth. And she did this in addition to the work at the supervised injection site, and then tried to develop a mobile treatment center for youth that was unfortunately shut down. And I'd love to know more about what happened there, but the site that was going to be available for youth overdose prevention. In her work as a community organizer, she supported families who've been killed by the police. She's developed support networks for undocumented individuals in Canada, and also provided a lot of training and popular workshops on issues such as conflict resolution, mental health, anti-racism. She's also been a street medic during demonstrations in Canada. So she has this very rich background that she's bringing to this work, very importantly from experiences in 3 different countries too. She's a registered nurse in Quebec and has a Bachelor of Arts degree in Latin American Studies from McGill University. So welcome, Andrea. It's a pleasure to have you with us.
Thank you. Thank you for having me here today. It's a pleasure to be here.
Great. So Andrea, can we start by, can you tell us a little bit more about yourself and the work that you are doing in Project DOPE?
So I started here at the DOPE project around a year ago. The DOPE project has been in San Francisco for over 20 years, even before I joined the National Harm Reduction Coalition. And It started as a community naloxone distribution program before it was widespread in the country. And the idea was to make naloxone available to people who are using drugs, because based on studies, based on experience, most of the people who are responding to overdoses are people who use drugs. It's the people around them. It's not going to be police. It's not going to be healthcare workers. It's not going to be paramedics. So our goal was to, how do we reach those communities? And that's how the DOPE project started. And a part of that was to, like, back in the day, it was like really hard to get naloxone. You had to get a prescription, you needed a doctor. So they developed this like community-based overdose response. And currently right now, it's much easier in California and San Francisco to do that. But we still, our goal is to reach to communities who haven't been reached yet by harm reduction programs. So Black and Latinx communities are still disproportionately affected by overdose deaths. So we're reaching to those communities with naloxone distribution and overdose prevention trainings. We also have another pilot project that started during the pandemic, which is our SRO DOPE project, which is training staff and residents in supportive housing. So SROs, shelters, and navigation centers on how to respond to overdoses, how to change their policies, and also to make the residents themselves trainers, and also to be the ones to like distribute naloxone in their building.
Wonderful. It's amazing that, you know, the history of the DOPE project and really how long it's been in existence and really evolved to respond now to the fentanyl crisis that's occurred. Just a great work. Wonderful. Can you tell us a little bit, you know, talking about the fentanyl crisis that we're in, how does it differ from prior crises that have occurred related to opioids?
I think the thing that has happened with fentanyl, one is that it's how it showed up, I think, in communities. Like, it showed up in San Francisco, it started showing up in 2018, where it was in Canada, it started showing up around in full force around 2020 during the pandemic. And I think one is that people were not prepared a lot of the times. Like, it just sort of hit. Overdoses were like much larger. Overdoses did not look like they used to look. For the most part, they're much faster. And then people also didn't expect that people actually would want to be using fentanyl. But it's not just about a supply being like cross-contaminated. People are actually seeking that particular high as well. And that's one of the things. And then there's also been a lot of, I think, paranoia in the media and a lot of misinformation around fentanyl about what it is. And those are some of the things that I've seen. It is still an opiate. You still can respond to it with naloxone. But I think because naloxone hasn't been as wide distributed in many communities around this country, when people were overdosing from fentanyl, because it can happen very quickly and very fast and with a very small amount, as opposed to like heroin or morphine, it made it so people didn't know how to respond to it, right? Like, you couldn't just, it wouldn't just pass. Like, you had to actually use naloxone. When it's not widely accessible, it's much harder to respond, and then people are dying. So I feel like another horrible side effect, I think, of fentanyl being in our communities is that we've lost a lot of people. Like, I've lost so many people. One of the reasons I went into nursing was because I lost close friends of mine to fentanyl and to opiates. And that's one of the things that, like, on top of having to be in a community that people who use drugs, you then have to deal with grief and loss. And then it keeps happening. And it keeps happening when there's no access to naloxone, when there's no access to harm reduction services, and when there's still criminalization for the use of drugs.
Absolutely. And I'm sorry, you know, that it's just, this has impacted so many of us so directly. And that is brought to the work that we're all engaged in, definitely. You know, as you talk about this, you know, and looking at the poll, there are some folks who have have quite a bit of experience with fentanyl and harm reduction. But for those who don't, can you just explain a little bit about fentanyl? You were mentioning some aspects of it.
So fentanyl is a very strong synthetic opiate. It's been used in medical settings for a really long time as a pain relief. And the difference between like morphine or like heroin is that it's much stronger. So like, we talk about it being like 100 times stronger than morphine and 60 times stronger than heroin, which means that you need a very small amount to overdose for it to be deadly. And what we're seeing is that it used to exist in a medical setting, like you give it for pain medication, for cancer, for like to relieve pain in medical settings. And then it started showing up in the street supply. And when it started showing up in the street supply, one is because it's not very hard to make, it's very cheap, and it's like quite strong. So the way the high that people get from it is quite different from the high that people might get from heroin or morphine. And it also means that like you don't have to spend a lot of money for it. You need a little, very little, but because you have an unregulated street supply, there's a higher chance of it being mixed with other things. You also have a higher chance of not knowing how strong it is, how much you're taking, because you can't really control, like, is it going to be a lot or a little? And that can make it so people cannot quite predict how much they're using sometimes. In the way that people got used to with heroin and morphine, where like, I've seen people who have been using heroin for like 20, 15 years. And then fentanyl showed up and they were dropping like flies and I say dropping like flies, I mean like overdosing. Thank God we were there to respond. But that was because you couldn't control, you didn't know, like one batch would be like really strong and the next batch would be much lighter. And that unregulation and that, like when you have like an unregular supply, criminalized supply, it makes it much harder for people to respond. Mm-hmm. And that's what started happening with fentanyl. And then because of the small amount you need, it's much easier for it to be mixed in other drugs and not for people not to know that it's there as well. So I always tell people to focus on what an opiate overdose looks like rather than what people are taking. Look at the signs of an overdose rather than looking at like, oh, this person took meth and then be like, yeah, but they're like non-responsive and not breathing. That is not usually a response to meth. So like focusing on symptoms rather than what drug they took. And that's the other thing that started happening. You start seeing it mix in other drugs as well, like, or whether it's through cross-contamination or because they're actually adding it to the drug. We don't know that very well, but that's part of what was happening as well. And another thing that I would say, like, this is just like fentanyl is just a continuation of like when you criminalize the supply, when we saw like the increase in opiates being prescribed and then people being cut off as a response to that, like doctors and healthcare providers and healthcare systems decided being like, okay, how do we address this like over prescribing of opiates? People were already using opiates, so they ended up going to a street supply, right? Like in the street supply, it's like how fentanyl, that's just a continuation of that as well. And that's part of criminalization of drug use, right? Like people are just trying to survive.
You mentioned, to focus particularly on the symptoms, because we don't know what is in drugs. We do know that there are multiple substances that you can count on it pretty much. What are the main symptoms you recommend when you are in your trainings for people to look for?
Yeah. So when you're looking for it's the same symptoms that's an opiate overdose for the most part with fentanyl. It is an opiate at the end of the day. So we will work on the respiratory system. So the main thing that happens is that it will slow down breathing. That is what opiates do. That's what fentanyl will do. It will slow down the breathing to the point that people stop breathing. And as a response, people become unconscious, but they don't have enough oxygen in their body, in their brain. And then they'll stop breathing and their skin color will change. So you'll notice that their pupils will get very small. Their skin might change color, or their nails or their lips. So people who are darker skin might get like a pale gray, sometimes like purplish tinge. People who are lighter skin might get like a bluish, pale gray tinge in their skin. If you touch your skin, it will be pale and clammy. And you might sometimes, if it's been a while, you might get this sort of like gargle noise in the back of the throat, sometimes called a death rattle, or sort of like it's like your body's trying to get oxygen. So it's just like trying to squeeze anything it can to get the oxygen into the body. And those are the symptoms you're going to see. The added thing with that we're seeing with fentanyl, and that can happen, is like rigidity, which can be a problem if you're trying to give someone oxygen. So what happens is sometimes what happens when people overdose from fentanyl, so like they'll get rigid. So they're like, their jaw will clench, their arms, their hands, their whole body will get rigid, like tight. It doesn't happen all the time, but it can happen. And that's an added thing that doesn't happen with all opiates. And that means that when you're responding, it might be hard to open the mouth if you're trying to give respirations or give oxygen, which can be one of the complications with fentanyl. And then the last one that I have never seen this, but I know that people have reported this, is called a wooden chest syndrome, which means that if you're like if you touch your chest and you knock, it feels like wood. Like it's like a very different feeling, which is something that's particular to fentanyl as well.
Thank you. That's very helpful for people to be able to recognize those symptoms. The other thing is, given all the work that you're doing, what are you finding is most useful in terms of harm reduction for individuals that we can do as programs for addressing the issue of substance use disorder for people who are using fentanyl, and from a harm reduction perspective? I should also just mention, in addition to today's talk, there was a prior talk that was very focused on more of the medication-assisted treatment. But today we're focusing primarily on harm reduction. But just so you know, that is available. Adriana Campbell from the Bridge Project did that presentation. It's available on the website. But we're so fortunate to have Andrea, who's talking to us about the harm reduction. So from that perspective, what do you think? What do you think is most important for folks on this program to know?
I think I'm gonna one of the things I want to say is, like, I think the main thing is to listen to what people need and want, like stigma. Like, one, breaking down your own personal stigma and recognizing the stigma is prevalent in our community because of the war on drugs, because of criminalization of drug use. So even your own clients, participants might have internalized stigma. So trying to build trust and just show up where people are at. Not everyone's going to want treatment. Not everyone's going to want to stop using drugs, and that's okay. Like, you want to show up there where people are because you want to avoid people dying. And that is what happens when there's stigma. And I'm not like I've had close friends of mine who are harm reduction workers who were just their own internalized stigma. They died because they wouldn't share that they were using drugs. And that's something that I just, like, for me, work on that. Everyone needs to work on that in our own spaces, and not just assume that because we work with people who use drugs or we care about this that we don't have stigma. It's internalized. It's part of our society, right? That's a very, like, general one. Because I think that kills a lot of people. And the second thing, the more practical side of, like, harm reduction things that people can do, naloxone, just, like, know how to use it, have it around, have it accessible for people. Don't limit how much people are getting, just to give it to people. A lot of it's going to be people who use drugs who are the ones going to be respond to overdoses. So people are asking for 10 kits, give them 10 kits. And limit the barriers of access, right? Like, don't ask them a million questions of why they need it, why they're using it, because that actually will create a barrier of people being able to access it. Remember that people in your community might be like, you might have people in your life who are using drugs and you might not even know it. And just, like, being able to open those conversations up in every space you're in. It can be coworkers, friends, people in your community, your clients. Like, building the trust with people makes it easier for people to trust you and to talk about what their drug use is. The other thing I want to say is that if people are using fentanyl, there's some, like, more practical things that people can do. We've talked a lot about switching from injection to snorting or smoking fentanyl. One, because injection use, there's a lot of side effects to injection use. Obviously, like, there's a lot of, like, people can get, like, HIV if you share needles, especially if there's not access to clean needles and things like that. But also, there's a higher risk of overdose with injection because it goes straight into the bloodstream, which means that it's much faster for people to overdose. Whereas smoking or snorting, people are still going to get high, but it's just there's some delayed risk. There's some delay a little bit, and there's, like, a less chance of people overdosing than if they're injection versus injection. And that can mean that in your community, like, what does it mean for people to access clean pipes? Clean smoking supplies, right? Like, so they're not sharing their pipes, so they're not smoking from a broken pipe, so they can use clean supplies. What does it mean for those, like, policies in your community, in your organization? Like, how do you give that out? Also, like, not limiting the access that people have to those things as well. That's another thing that I want to say. Also, reminding people that even if you know your dealer, even if you know your supply, even if you're testing your drugs, like, fentanyl test strips are great. They're a great tool. But fentanyl test strips, for the most part, will test mostly this for positive. You should trust the positive result and not the negative, because a lot of times fentanyl would not mix well with other drugs. So there might be a pocket that you just didn't test when you were testing it. So reminding people to that if you're going to be testing your drugs, to just, like, always trust your positive result, less the negative result for that. And that if you're going to be mixing with other drugs, always try to start with the opiate or like the fentanyl before you mix anything else, so you know how it feels in the body. Even if you know your supplier and your drug, making sure that you are using less. Every batch can be different. I was sharing this with Mary. We were having a conversation earlier when we were working at this. When I was working at the supervised injection site, we were just like, we stopped relying on what people were telling us they were using. We just started like just being like, what batch is this? Like, because we had to like, every batch was different. Some batches was fine. Some batches we would get the next day a different batch, and that batch would be like everyone would be overdosing that day because it was so strong. So we like, so just like use less. We always tell people use less. Like if you're not sure, just use less, use slower. Another thing that I tell people is try not to use alone. This can be really hard for a lot of people, especially because of stigma. Especially because like people sometimes create rituals around how we use drugs. So, but a lot of overdoses and deaths are happening because people are using alone. Like I can give an example that happened here in San Francisco, where like during the pandemic, a lot of folks who were like who lived on the streets, who were like didn't have homes, were put into shelters, into SRO, supportive housing, which was it was beautiful. I'm glad that they had a place to be, but that took away their community. Suddenly they were all alone. Suddenly they were using their rooms alone, and there was no one there to respond. And we saw so many deaths happen in those buildings because of that as a result. And that's something that happens. So making sure there's community around, and that means like if you're going to be around them. Another tool that I've used to use with friends who didn't want me there physically, I would just stay on the phone with them. Like I would just put my phone on and be like, we agree that if you didn't respond to me after 5 minutes, I could call 911, or after like we made a time agreement depending on the batch, what was happening with the supply. Check in with people in your community about what the supply is looking like. Like people who use drugs know. If things are changing, they will tell you that things are changing. Especially if we don't have testing. San Francisco is just starting drug testing here. Drug testing does help a lot because you can like know, but it's going to be the people who are going to know the first are going to be people who are using drugs. So like talk to them, being like, what is it looking like right now? What is it happening when you're responding to an overdose? How are people like feeling with this batch or that batch? So some like more practical things that I think are useful. And then there's like things that can just in general in harm reduction tips, which is to just like always remember to listen to people who are directly affected, like incorporate them into your policies, decision makings, into your organizations. Like what does it look like to work with people who use drugs? What does it look like to make decisions, to make policy, to like provide programming based on the experiences of people who use drugs, not on what you think is best, not on what you think that should be happening, but based on what people are actually experiencing. And like I am in San Francisco. San Francisco looks very different to a rural area. Canada looks very different to the United States. There's things that can translate, but there's things that are very specific to the area you're in. And that the best thing you can do is just talk to people or be around people who are directly affected. Like if you're someone who uses drugs, your voice, that's what should be listened to. Yeah.
Thank you. There's so much there, and I love how you started with trust and with listening, and in also involving people in policy development. And I really have enjoyed all the responses from our audience, all the love that's going out, and appreciation of your perspective. You mentioned, there's the differences in Canada, and some that when we had an earlier conversation that you mentioned is, for example, primarily you're using injectable naloxone.
Yeah.
Can you talk a little bit about the advantages of the injectable naloxone over the nasal application?
Yeah. So I am a nurse. I do want to start with that. Like I do train as a nurse, but even before I trained as a nurse, before I went to nursing school, we only had injectable naloxone where I was. One of them in a lot of parts of Canada, I think that's still the case, especially in medical settings or in harm reduction settings. That's what you use injectable. There's a couple of reasons for that. One of them is you can titrate. That means that you can use less. Our goal, I feel like we had our supervised injection site and a lot of harm reduction places that I've worked, is to the last thing we do is use naloxone. We try with oxygen first, and then we use naloxone. The reason for that is that because we want to avoid putting people through withdrawal. We want to avoid putting people through unnecessary withdrawal when they don't have to, because we're listening to the voices of people who use drugs. If you are someone who uses drugs on a regular basis, you're opioid dependent, you do not want to be Narcan a lot of the time because the withdrawal symptoms are horrible. And the other thing that happened a lot to us was that people would straight up like lose trust in us. They would just not come in anymore. We had people just use right outside our door just in case they overdose, but they didn't want us to Narcan them. And as a response to that, we're like, okay, how do we address this lack of trust? And then you start listening to me like, yeah, because people do not want to deal with withdrawal and dope sickness, but they don't have to. So injectable naloxone gives you the option. One, it stays in the system for less time. So stay in the system for like 20 to 30 minutes in the system versus like 90 minutes to 2 hours in the nasal kind. So when you're giving it to someone, there's a less chance of someone going through withdrawal because it's so short how it stays in the system. There is a small chance that people can re-overdose, but if you're staying with them, you can just give them another dose when they overdose again. I was very lucky that I never got to see that. I responded to hundreds of overdoses and we never saw someone re-overdose. But I'm not going to say they cannot happen. The nasal kind is extremely easy to use. That is true. But there is that risk that you're putting someone who is opiate dependent or uses opiates on a regular basis through a longer period of withdrawal or dope sickness. The other thing that happens is the price difference. And this is something that like might not be a big issue when we have like funding, but when we think about how harm reduction is funded overall, we're spending like the nasal naloxone right now in California costs around a little bit less than $50 for a pack of 2. The injectable kind will cost like $1 to $2 for a vial. That price difference doesn't feel like that big. It is still big, but when you look at it like last year, the Dope Project distributed, 63,000 doses. That makes a big difference, in terms of like that money could be going to pipes, could be going to like giving people like wound care supplies, like all the other things that come with people when people use drugs, right? That are also part of harm reduction. Those are the two main differences. I do want to say that they're both great. They're both like, that's all you have, that's all you use, right? Like, I'm not telling people not to respond to an overdose. I'm just being like, how do we respond in a way that also respects people who use drugs, that we do not put people through unnecessary withdrawal if we don't have to, and like that we actually respond when people are overdosing, and not just from a place of panic. Because I will say it is hard. Watching someone overdose, or if you're not sure if they're overdosing, it is a very scary thing, and that is real. But remembering that, like, yes, we want to respond when someone is overdosing. And how do we do it in a way that respects people who are using drugs and listen to what their experiences are like?
Thank you. Very important. And also you'd shared that you do trainings and both in English and are doing in Spanish also, where you show both the nasal formula and also the injectable. So that's great. And individuals who are using drugs are knowledgeable about about injecting. So it's another advantage of the injectable. So great. Thank you so much. And what barriers do you think are the major barriers at this point in the United States for really implementing these great harm reduction strategies you've mentioned?
I mean, the war on drugs, all the stigma that exists around drug use. I think there's still I think I'm also coming from Canada. So for me, I'm still seeing the United States as some things that I learned is like, they're not based on people's experiences. They're not based on what people who are using drugs actually are asking for or need. They're based on what politicians think, they're based on what medical staff thinks, and not actually what people are experiencing. And I feel like that lack of connection is killing people. The fact that I recently, in San Francisco, we started giving out pipes 2 years ago. People have been smoking meth and crack for a long time, and we just started giving out pipes because there was no funding and because there was a blockage towards that. Being able to give people the resources they need to be alive, to base our practices in institutions and in policies on harm reduction, and not on political fears. I think that's one of the biggest barriers. And stigma. I feel like I'm not going to deny that being in community having family members, if you're someone who doesn't use drugs, it's not hard. I come from a family where my dad used drugs for a long time. It did mess things up, but I love them, you know, like I don't want my dad to die. I didn't want my dad to die. And thank God there was people in his life who like were able to care for him in the way that I feel like when we want to prioritize the survival and the care for people who use drugs, building trust, being able to provide people with the things that they need and not just based on policies or what we feel they need, like listen to their own experiences is important. That's one of the barriers that I see. Also, like so much misinformation sometimes. Like I feel like every training that you do on naloxone, I have to always spend some time talking about being like, yes, you cannot overdose from touching fentanyl. That is not possible. There's something in between. All those reports about the police force like overdosing from touching fentanyl and then driving themselves to narcan themselves. I'm like, you can't. Things like that I'm just like, they're small, like there's those misconceptions. So trying to break those away. It is scary. And like and then the larger issue, like drug use doesn't live alone. It's part of like a larger systemic thing. Like it's about housing, it's about food, it's about race, you know, it's about the things that are part of our society that also need to be addressed. Like in San Francisco, for example, we're seeing so many people who've been displaced because of housing. And that is leading to like difficult conditions, to isolation, to them being like not having housing. We've also seen, like I mentioned at the beginning, like in San Francisco, on a positive note, I think we're one of the only cities in the country that has lower the amount of overdose deaths that have happened. So we went from 725 people who died from overdoses in 2021 in 2020 to 620 people who died from overdoses last year, which is a big deal because most of the country it's been the opposite. A lot of it has to do with the policies that have been in place, with naloxone distribution. But even despite those numbers, we're still seeing that Black communities are disproportionately affected by overdose deaths. And that's a race issue, right? Like, what is it happening that we're not reaching Black communities? What is happening that we're not able to provide care, like, to those communities and to provide harm reduction services to those communities? How do we work with Black communities to be able to provide that care? Same thing with Latinx communities. Like, one of the reasons that we're doing the Spanish training is because we want to be able to go to Latinx communities and do it in Spanish, so people like in their communities can understand in your own language rather than having translation. So that's why we're doing trainings in Spanish as well. So those are like some of the things that we're like trying to address, and like that I think are like some of the barriers that also exist. And also, I can go on. Thank you.
Yeah. Thank you so much. Great information. And it's kind of following on that, are there, what is the most effective messaging, the most effective way to communicate about fentanyl? You were saying disproportionately impacted communities and everything. What would be the approach? I think you've mentioned some of these areas before, but how do you approach that in the DOPE project? How are you going to reach into, you're saying within the Black community, within the Latinx community? How do you approach that in terms of how your messaging and communication regarding fentanyl?
So one of the things is like breaking down some of the myths, like remembering that fentanyl is still like, it's an opiate. It's just a drug. It's not this like devil evil thing. And being honest about what it does. I feel like that is useful to people to like take away the fear a little bit that exists. We also, like the DOPE projects, we're intentionally reaching out to those communities, and that takes time. That takes building trust. There's also like, I got hired because I'm bilingual, not because I'm bilingual, but part of it because I speak Spanish and I'm Latina, and that's how I'm reaching to Latinx communities in their own language as well, right? Now, with the Black communities, this has been work that we've been doing for over 3 years, where we're like reaching to Black community centers, Black community groups, and working with them and having conversations and being like, okay, why don't we start with what does it look like to respond to an and to address sort of like the barriers that exist that are institutional, like that historically Black communities have been targeted and have been like not supported by the state, by healthcare, and the resistance that can sometimes comes because they've been portrayed in ways that are racist. And how do we address that while still talking about harm reduction? And that takes conversations, that takes time, that takes showing up, going to events, talking to people, reaching out to people in the community, both elders and also youth, like to people who are using drugs in those communities, and being like showing up in presence. And something that means also shifting who we're focusing on. But that's something that we can do at the DOPE project, because we live in San Francisco, where there's a lot of harm reduction programming. There's a lot of people who are offering things, which might feel different in other communities, I will say. And then I think the other thing that I find that's effective is just like, naloxone is great, like giving out naloxone as much as you can. It's something that's not hard. It's not hard to use. You can learn it. You can carry it with you. And also I want to say that for me, I'm coming from a context in Canada where like fentanyl was not the thing we're worried about. There's things that are so much stronger than fentanyl in our supply, and still are. We had benzodope in the supply, we had psilocybin in the supply, we had carfentanil, which is 100 times stronger than fentanyl. I was seeing people overdose with like, they had the needle on their arm and they're like talking to me and they turn blue in front of my eyes. Like, those are the things that we were dealing with. Like so for me, fentanyl is just like, it's an opiate. It is very scary, but there's things that can be much worse that I've seen. And there's things that are much worse. Like when we think about wound care, like infections, diseases that carry that, fentanyl, we can reverse an overdose. You just naloxone, that's how you're gonna reverse an overdose from fentanyl. It's something that is like, we can do things about, right? I think the talk that happened last week about treatment, that's great. Like if people are ready to go for treatment, great. But not everyone's going to be there, and you might as well show up where they're at until they're ready if they want to. And I feel like showing compassion and care makes a big difference.
Thank you. You certainly communicate that so effectively, Andrea. We really appreciate that. We're going to switch now to some of the questions we have quite a few questions I'm seeing here. And you've talked about some of these, so I might skip around a little bit. One was, how does stigma play a role? And you were talking about that. Let's see. You talked about the background, a lot of great questions here. So this is, should there be different messages for people who are actively seeking fentanyl versus people who consume drugs contaminated with fentanyl, but that's not their intention to use fentanyl?
I feel like, yeah, go ahead.
No, go ahead. How do you just, that distinction, with individuals, how do you address that?
I feel like it's the same. It's like people are using drugs. I feel like you should like focus on the symptoms, being like, if someone is using drugs, using fentanyl intentionally, they know, they'll know, like being like, hey, just have someone around you who's using naloxone, right? Like if case they're using. But a lot of people use drugs, no. They'll know for the majority of part, especially in the bigger cities, bigger spaces where there's harm reduction, how to carry naloxone to use with our own other people. They don't want to die. And then for people who don't like intentionally seeking that and then they overdose, I'm like, for me, the easiest thing is to be like, just have people around you who have naloxone, just assume that there might be something in the supply. You cannot, because of how shifting the supply is changing, how much it's changing, you might not know. Like, there might be times when like, you think you're fine, you tested your drug, you got it from someone you trusted, and you might still overdose. And when that happens, if you have someone around you who can use naloxone, people are gonna be okay. You're gonna reverse that overdose, they're gonna be fine. So for me, it's like either or, the message is gonna be the same. Like you wanna just have someone who knows who's around you, who can have naloxone with you. Because you can't predict. The drug supply is changing too fast, I think, to predict that.
Thank you. Thank you for that information. We've got several questions here that have to do with the actual dosing of naloxone, and you'd talked about this with, putting people into withdrawal. One question is very specific: how many 4 milligram kits are you seeing being used to revive individuals? There's been some marketing of higher dose naloxone because of the assumption that you will need more naloxone to revive somebody with a fentanyl overdose. Can you talk about that a little bit?
Yeah. So Okay, so there's two things I want to say. The first one is like a lot of my experience reversing overdoses came from working in a supervised injection site where I was watching people use drugs, right? You're watching people inject, you're watching people like in front of you. So you're seeing that's sort of like a lot of my experience. And then secondly, there's I have some experience with like responding on the streets as well, which is a very different experiences. I don't have experience responding in housing, which is again a whole different ballpark because you're showing up after you don't know how long people have been overdosing. I just want to give that caveat. I am not I believe that the 8 mg doses are not necessary. The main thing you want to focus on is respiration. Like even if you have no naloxone, you can just give respiration to someone or oxygen, and you're going to keep them. You're going to be able to give them oxygen until whatever drugs in the system wears out. Naloxone will make that process faster, for sure. But with fentanyl, for example, in San Francisco, we're seeing 2 to 3 doses per reversal overdose. When I work at the injection site, we would always start with oxygen, unless we had cases like the one I just described, where like the person was like turned blue in front of my eyes. We've later figured out there was like a mix of carfentanil and benzo. That's why it was so strong, which is not the case everywhere. Just with fentanyl, I feel like you just follow the process of an overdose. Giving more doses won't make it work faster. You know, it's still going to take 3 to 5 minutes to work. You give them oxygen. Like that is what matters. Like giving them oxygen, making sure they're getting into the brain so the brain can like respond to that. And you just wait for the doses. I talked also about titration. Like, so one of the things, like I would really look at BC, British Columbia, Canada. They're doing some incredible work that's very much based on people's experiences, and people who use drugs are guiding those policies. In those sites are using like half a dose. So they will give some people half a dose, just enough for them to get over the overdose. And then they will use oxygen because the goal is for people to stay alive, but not to put them through a necessary withdrawal, right? Obviously, this is very different if you're in the community, if you're showing up when someone has overdosed and you don't know how long it's been. But no matter what, you're still gonna have to wait for the medication to work before you can give another dose, right? Like it's still gonna take 3 to 5 minutes. And sometimes it will wake up after one dose if you wait like 3 to 5 minutes. When I was in Canada, I think the most I ever gave someone was 8 doses, and we were waiting 5 minutes between doses because there was carfentanil, and also the person taking benzos and other drugs as well. Like, so that's another thing that can happen as well, I would say. In San Francisco, where we only have fentanyl so far in supply, we're seeing the communities reporting between 2 to 3 doses per overdose reversal. Yeah, but the 8 mg one, I know it's something that a lot of paramedics are using, but I feel like you're risking putting thermals to withdrawal when you might be able to use the smaller amount, you know? I feel like the focus should be on giving people respirations and giving them oxygen. Naloxone will help for sure, but you're able to keep someone like with their oxygen going. That's what's going to make the difference.
Thank you. Yeah, it's a really important subject, and I think it ties back to that kind of some of the myths about fentanyl too, but we, having the advantage of a supervised injection site would be, hopefully we will get there in more places soon.
Yeah, I hope so too.
There's a question about, how can we prepare for the coming wave of xylazine, but other, there are other medications, there are other combinations. How do you, within harm reduction, make sure that you're responsive to what's coming into the community?
Mm-hmm. So that's what happened to us, to me, I guess. We saw the shift in supply where I was really quickly. We saw the arrival of fentanyl, and then we saw the arrival of benzodope, which is something that's not as, well, at least in San Francisco, we haven't seen it as much. Benzodope was a mixture of whatever drug people were taking, had fentanyl and a benzo in it, which meant that when you were responding to an overdose, naloxone will work on the opiate, so the fentanyl, but it will not work on a benzo. So a lot of times what would happen is that the person would sort of come up and then they would go down again, but they were breathing. And eventually they'll forget to breathe. You would wake them up, they will take a deep breath, and they would fall back again and stop breathing again. So you had to basically sit with someone for 2 hours, just making sure you're shaking them and like being like, hey buddy, just breathe. And they'll breathe again. You could wake them up, but then they would fall back down again. And they couldn't breathe on their own if you reminded them. And that was very jarring for a lot of us, because you think about people on the street, who's going to be there waking them up, right? It was very scary because naloxone, we suddenly saw naloxone not working. It was working, but only for the opiate, not for the benzo. And a lot of times, like, it was also pandemic time, so we couldn't really send, the hospitals were overwhelmed. It would take an hour sometimes for the ambulance to show up where we were. So with psilocin, it's the same thing. What's happening is like psilocin is a tranquilizer. So we're seeing that when you give someone naloxone, it is responding to the opiate, but it will not respond to psilocin. You need to send some, like sadly at the moment, like you can give them, if you have access to oxygen, you can try oxygen, but for the most part, you need to send them to like a medical setting for them to get treated in those moments. I think one of the things that I say to people, and I've mentioned this already, is to just like check with people using drugs in your community, like talk to them, build that trust so they trust you to share this, be like, what are you seeing? This is something that we will always do. Like we were like, when I was working in community, like you always ask people like, what is changing? What are you seeing? Like, and people will tell you things, and you have to trust their information. Sometimes it might not be as reliable in the way that everything is, but like you trust what they're telling you. I think if you're able to have some sort of like drug testing in your community, you can ask people to trust those drugs. It's much harder in the United States because it's so illegal here to use drugs. Whereas in Canada, you had like all these exceptions that people could use in certain spaces. We could test those drugs and know what was in our supply, and like be able to warn our community as well about what was happening. That's one of the things I always think about, it being like, listen to what people are telling you. People are telling you that things are feeling off, or they're seeing a lot of people overdose suddenly, something has shifted. Mm-hmm. And being able to listen to that and adapt to that. I think with psilocin, what I'm seeing is that it is very scary, and it can be very hard because you're like, I'm using naloxone and it's not working. It is working for the opiate a little bit, but you also, like for the psilocin, you need to like send medical help until we can figure out better ways to respond, or where we have more access in our community to actually things that can help people.
Yeah, very important, that realization that naloxone will not take care of everything, you know, that you have to assume that there are other things if you're not getting a response. And yeah, definitely. I apologize, we're not going to be able to answer all these questions. We have so many great questions. One that you briefly talked about was fentanyl-laced marijuana. What is there are kind of some, that's an area where there's some myths and there's some reality. What is your experience with this?
Yeah, so this is something that I've heard a lot. One thing that I do know is that fentanyl, the moment you burn fentanyl, it stops having any effect on the body. So we've heard a lot about like people smoking joints and then like overdosing from that. But like if you're burning the fentanyl, most likely it will lose its effect on the body. Like you have to, for fentanyl to work, you have to like, you can't burn it directly, you have to burn it through something, usually a pipe or aluminum foil. That's usually how people smoke the vapor in. That's one thing I know. I will also say that a lot of the times there might be something else going on, like maybe someone took something else, and because of stigma, they're not talking about that. I would also, again, focus on the symptoms, right? Like, so a fentanyl overdose will look like someone is non-responsive and not breathing. But if they're breathing and they're not responsive, then it might be something else. It might not be fentanyl, right? But if you have those two, then there might be, maybe you took something else some other time and not letting you know. That's usually when I hear about that. That's what I'm always asking those questions, like, well, were they also taking something else that we just didn't know about? Did they actually overdose, or did it look like an overdose and you thought they overdosed and people just used naloxone because they thought it would work? That's some of the things. But I know, like, scientifically, the moment you burn fentanyl, like with fire, it stops having any, it cannot be absorbed by the body.
Thank you. That's very, very helpful information. I'm seeing we have 69 questions, Andrea. So we will hopefully work with you to get responses to these, but it's amazing that you know, you just generated so much curiosity, desire for more information about this very important topic. And we're almost at the end of our time too. So my apologies to not being able to get to everybody's questions, but I just want to thank you so much. This has just been an excellent information that you've provided. And we also want to let everybody know the DOPE project has a great website. Also, we have a website where there's information, but thank you so much, Andrea. It's just been an absolute pleasure having this opportunity to speak with you.
Thank you so much for having me today. And good luck to everyone out there.
Great. Well, again, remind you that if you need any, we have additional information on our website, also including the medication-assisted treatment, the fentanyl a webinar that was focused on treatment. And this webinar will also be available. Just really want to thank Andrea Figueroa for being with us. And that's a great resource, the DOPE project, that you can all see on their website. It's just a great, there is increasingly more information available. And I want to end by thanking you all, those of you who are working directly with individuals who are experiencing overdoses with fentanyl, those of you who are beginning to learn about this topic. Thank you all so much for joining us today. We really appreciate it. We do have another webinar coming up on February 28th, Managing Toxic Stress and Burnout, 7 Types of Rest. This is tough work, and it's important that you take care of yourself. You know, you get that the mask on you before you can help anybody else on that plane that we're all on. So we hope you will be able to join us for that presentation. Oh, great, that is it. Once again, thank you all for joining us, and thank you so much, Andrea Figueroa. Goodbye, everyone.